Hi, everybody. This is a recording for week 4. We're doing postpartum. And I'm going to share my screen and we're going to get started. So this week we're talking about postpartum. We're talking about from delivery on. Okay, and the acronym that we can use to give us an idea of what we are assessing on our postpartum patient above and beyond our normal head to toe is the BUBBLE-HE acronym. And these are the things that it's standing for. And we're going to go through each one of these individually. So we're going to talk first about breasts. What happens when the baby's born? Okay, we have this hormone that's been maintained the pregnancy, right? We have progesterone, and now it's falling. Progesterone drops as labor starts, and as this goes down, the body is told to release prolactin. Prolactin is going to be something that tells the breasts to start making milk, filling with milk. Okay, and this is going to be something that becomes a give and take between prolactin and another hormone, which is oxytocin. Oxytocin, we know, helps the uterus contract. But the other thing that it does is it lets the breast let down the milk. And so these two will work together for all of breastfeeding. Prolactin tells the breast to fill, oxytocin tells the breast to empty. Okay, so the body starts releasing prolactin and starts triggering milk production. Oxytocin tells the breast to let the milk down. And it also helps because it encourages the uterus to contract. So when we talk about breastfeeding later, we're talking about all the benefits of breastfeeding. One of them is that it helps the uterus to contract. Okay, we start out with colostrum. Colostrum is also called early milk. It can be expressed at birth, and it's thicker and more nutrient rich than breast milk is because the baby's tummies are very small and they only need a very small amount in those first couple days. And colostrum has all of the fat and nutrients that they need. Okay, excuse me, somewhere around 72 to 96 hours after birth, so like 3 to 4 days, that's going to transition from colostrum to mature milk. And then breast milk is constantly changing to meet the needs of the baby. If a mom does not want to breastfeed, we don't want her to stimulate her breasts at all. Okay, because of this loop, this prolactin oxytocin. Every time the breast empties, prolactin will say, let's fill it back up. So we don't want to encourage the breast to empty. So there's things we can do. We don't want them to stimulate their breasts. We don't want them even using warm water. Warm water helps the breast let down milk. They can put ice packs for comfort. Cabbage leaves helps with discomfort, and they can take ibuprofen because what we're going to talk about next is engorgement, and engorgement happens regardless, but it's a lot more uncomfortable for those that aren't breastfeeding. Because engorgement, when the milk first comes in, the breasts fill a lot. The body doesn't know how much the baby's going to need, and it makes a lot of milk. And so engorgement causes the breast to be hard, firm, tender, and uncomfortable. And if they're breastfeeding, there's a lot of things they can do for that to relieve that pressure. They can feed their baby. Okay, they can also use ice packs between feeding, and they can hand express milk, things like that. But for your mom who's not breastfeeding, this is going to be more uncomfortable for her because we don't want her to let any of that pressure off. We want to promote breastfeeding for the moms that plan to breastfeed. And the first 1 to 2 hours after birth, when we're in that 4th stage of labor, is the perfect time to get baby latched. Baby is alert and interested and showing feeding cues and all of these things. Okay, we're assessing for sore nipples. because if the baby doesn't latch effectively, there can be cracks and blisters on the nipples. And then we also can assess for mastitis. And truly, this is probably not something we would see if we were in the hospital with a newly delivered mom, but it's possible. And mastitis is a unilateral infection of the breast. It happens on usually one side, and it causes moms to feel really bad, like flu-like symptoms, fever, and things like that. And we're going to talk more about mastitis with infections in a little bit. Next on our bubble acronym is U for uterus. Okay, these guys, you're going to need to know this. All right, the idea is the uterus is supposed to contract and slowly go back down to its non-pregnant state. Okay, and this is called involution. All right, if this doesn't happen, we have a problem. And this is subinvolution, if the uterus does not go back down to its non-pregnant state. And this is usually caused by something that's still inside the uterus, like retained placental fragments. And sometimes infection can cause it as well. And subinvolution can lead to hemorrhage, which we're going to talk about today too. Inversion, I mentioned this with our week 3 stuff. When we're waiting for that placenta to come out, the provider shouldn't be pulling on the umbilical cord because it can cause the whole uterus to turn inside out. If this happens, this is a medical emergency. Okay, the uterus can't contract if it's inside out. And so all these big vessels can just hose blood. So hemorrhage, pain, shock, all these things can happen. Okay, so that's what inversion is. We also are mindful of inversion when we're doing our fundal checks. I'm going to show you that on my bear. All right, contractions. So we want the uterus to contract down. The placenta comes out. We have these huge vessels that have been feeding the placenta, and we are relying on compression to stop those from bleeding. All right, so that muscle has to contract down and squeeze those vessels. So we can give her Pitocin or oxytocin. And she also has her own oxytocin circulating within her body. All right, and so both of these things together work to help compress those vessels and keep them from bleeding too much. Other things that because this is contracting, it's going to be uncomfortable. It's going to be crampy and painful. We call them after pains. And it does seem to be worse with subsequent pregnancies, subsequent babies. And when baby sucks, her body's releasing more oxytocin, and that's a prime time to have more after pain. Okay, so sometimes for some women, if they're really uncomfortable with their after pains, even giving them Tylenol or ibuprofen before they feed their baby can help. So here's the other part of the uterus. So what we're going to be assessing is we want to know where the fundus is. And we mentioned this in class as part of the stage 4. And this is going to be something that we continue to monitor throughout postpartum. Okay, and so we're going to palpate where the fundus is. And you guys remember that the fundus is the top of the uterus. And we expect that we're going to find it somewhere close to her belly button. All right, and so we want to support from the bottom and massage from the top. So here's her head. We're going to support bottom, and we're going to go in, and so we feel the top of the fundus, and we're going to massage that top of the fundus there. And supporting this is helping keep inversion from happening, because if I'm pushing really hard on the top, I don't want to accidentally turn her uterus inside out. So I'm supporting on the bottom, I'm massaging on the top. I want this to be firm. It should, when the baby's first born in those first 12 to 24 hours, the uterus often feels really solid, like a baseball. Okay, and as we get further out from delivery, you can still feel it. It still feels contracted, but it's not as pronounced. All right. And then we want to measure where we find it. And this gives us a really good indication of if things are changing, if they're getting better, if they're getting worse. So what we want to do for this is we're supporting from the bottom, we're feeling where we feel her fundus. And right now I'm feeling close to her belly button because that's where I expect to find it. But it might not be there and I might have to palpate until I find it. If her fundus is above the belly button towards her head, then we say that these are pluses. If we find her fundus below the belly button towards her feet, these are minuses. And so we say U for umbilicus, and then we count by finger widths. So if I find it up here, I would say U plus 1 finger width. Okay, and same the other way. If I find it really low and I find it way down here, I would say U minus 2 finger widths. Okay, and so we anticipate that the uterus is going to slowly descend back to its non-pregnant state, involution, and it usually is going to go down about 1 to 2 finger widths per day. All right, and we also expect to find it midline, so close to the middle of her lower abdomen. And these things are going to be important in a minute when we talk about signs that something's not right, okay? So those are the things we're looking for it to be right. So now we're going to talk about the bladder. This is the next on the bubble heat acronym. And there's a lot of things that affect the bladder. There's a lot of things that affect being able to void after you have a baby, because you just passed this human through an area that's very close to all those nerves that go to the bladder. And so sometimes they don't feel as the urge to void. They've had a person sitting on their bladder. The sensation's different. Maybe they had an epidural, so the sensation's still different from their anesthesia. Maybe they have a laceration. Maybe they have edema around her urethra. There's all sorts of different things that can contribute to this. But on the other side of it, we have postpartum diuresis. So she's gotten all of these fluids in labor, and now her body wants to pee it all out. Okay, so if she's not able to void appropriately and effectively, we can have bladder distension. So remember in week 3 with labor, we were managing the bladder, and I told you guys we have to keep managing the bladder. There's so much about the bladder. Okay, so now we still need to manage the bladder, because what's going to happen, guys, if her bladder gets full, is it's going to push on her uterus. And if it pushes on her uterus, it's going to tell that lower part of the uterus that it doesn't need to contract. And if the uterus isn't contracting properly, now we have a bleeding problem. All right. So the way that we can assess for bladder distension, there's a few things we can do. We can palpate and see if her bladder feels distended. And a study that I read says that on a person with a normal BMI, you should be able to palpate a full bladder with more than 300 mLs. And so you don't need to know that for anything but your brain to kind of understand that if you're able to palpate a full bladder, that's too much pee. Okay. Now, the other thing that can happen when the bladder fills up, as I told you, it can push on the uterus. So if I've been finding and documenting that her uterus is at the U and midline, and now I go in to assess and I find it up here, and it's on her right, close to her shoulder, and 2 or 3 finger widths above the belly button, that's a change. And that's not a good change. That's going to help me clue in that her bladder is probably full and that her bladder is pushing the uterus up and to the right. Okay. And so this causes uterine atony. Atony, absence of tone. We're not contracting our uterus well, increased risk of bleeding, increased risk of hemorrhage. Okay. So the other thing that can happen with bladder distension, hemorrhage is the thing we're really worried about, but it's also going to increase her risk of infection, right? Because we have this urine that's just kind of hanging out in there. The other things to remember for the bladder is we need to help teach Kegel exercises. And so Kegel exercises strengthen the floor, the pelvic floor. It strengthens the muscles for urination because there's a lot of pelvic floor trauma that happens with delivering a baby. Okay. We can also help assist with voiding we can run water. We can let them listen to that. Sometimes we have them void in the shower. All right. And there's all sorts of little tricks that nurses have. We put peppermint or wintergreen's better on a cotton ball and put it in a hat, set it on the toilet, and then have them sit and try to void. And sometimes that helps. There's all these things we can do to try to get them to void. But we're really mindful of if the bladder is distended, if she's emptying, and what's happening with her uterus for this. Okay, next on the bubble he is bowel. So it might take a few days for her to start having normal bowel movements again. All right. Some women do pass stool with delivery if there's anything down in that area. But otherwise, we've got so many things after that. We have so many things that are contributing to her maybe being constipated, not being able to go. And so we need to, as nurses, teach this. All right, teach how to promote normal elimination. And this would be when I would ask you guys, how do we promote normal elimination? And you guys told me this when we were talking about helping with constipation in pregnancy. It's going to be the same things. Okay, we're increasing fluids, we're increasing fiber, we're getting her ambulating. All right. We're being mindful of all the things that have happened to her in her labor. Maybe she has hemorrhoids now. She might have had medications that cause constipation. She might have lacerations. All right. And actually, guys, if she gets really constipated and she has a 3rd or 4th degree laceration, we can't put anything in her bottom. So we can't do like a suppository or enema to help her go. So being really proactive from the beginning is important. All right. So the fluids and the fiber and the ambulation and all that, sometimes they're on stool softeners and things to help promote normal elimination. Women who have cesareans especially can have excessive gas pain after they deliver their babies. And so there's some ideas on the slide on things you can do to help them with that gas pain. Okay, next is lochia. You guys need to know about lochia. Okay, lochia is the post-birth discharge. It is the bleeding. All right. And so we have lochia, we have 3 levels of lochia. All right, and they're over here on the left: lochia rubra, lochia serosa, and lochia alba. So rubra means red. This is that bright red bloody discharge that we see right after they deliver. And this is going to hang out for a few days like this and look like a period. All right. And then it should start to transition. So the word serosa, you guys should know that's like serous drainage, right? So it's got blood in it, but it's so it's mostly mucousy. And so lochia serosa happens usually through the end of the 2nd week. So our first few days we have rubra, then we transition to serosa, which is pink and mucousy. And then it should transition to lochia alba, and alba means white. All right, and this is going to be white or yellow. There should not be any blood in it, unless there's like a little tiny spot here and there. And it should not refer back. So once we are making this transition from rubra to serosa to alba, we shouldn't go back to rubra. If she's got serosa and now she's having bright red bleeding again, that's a concerning finding. Okay. And so we're watching her pads, and in the hospital setting, we're seeing rubra. All right. And we need to be mindful of how much is coming out. All right. We don't want, it is normal for it to be like a heavy period for her, but it should not be an excessive amount. If she's saturating a pad in an hour, that's too much. Okay. And so this is when we start worrying about hemorrhage. All right. The other thing that I missed saying is that if we move from Storosa or alba back to rubra, we're thinking maybe we have retained placental fragments or membranes. And we're going to notice probably subinvolution. We're going to notice that uterus not going back where it should be when we palpate. All right, so the next in the bubbly acronym is for episiotomy. And episiotomy, we don't cut episiotomies as often as we used to. This is where they make space on the perineum as the head's crowning by cutting the tissue of the perineum. More often now, we let that tear because they have found that the body gives exactly what it needs. And oftentimes that tear is not as big as the episiotomy would be. Either way, the way we manage these are the same. Okay, we can use Rita to assess for signs of infection. And we are going to teach her how to keep her bottom clean. All right, she should be changing her peri pad every time she goes to the bathroom. She should be keeping her bottom clean with a peri bottle. So a peri bottle is like a little squirt bottle. They fill it up with water, whatever temperature is comfortable to them, and they rinse their bottom off after they use the bathroom. If we want to inspect the area, we should have her laying on her side and then just gently look. And the other things that we can teach them about to help take care of their bottoms is to use ice packs, sitz baths, and then there's witch hazel pads and benzocaine spray that can help it feel better down there because it's going to take a little bit of time to heal. Postpartum infection, we're going to sidetrack for a second and talk about this. All right, so postpartum infection, there's a lot of different things that can play into this. All right, this usually happens within the first 28 days. And this is when we say that, keeping in mind the first 28 days postpartum is usually after birth, but it can be miscarriage, it can be an abortion, any of these things. Those first 28 days is when we're looking at postpartum infection. And what we see is we see a fever greater than 100.4, and it happens for 2 successive days. And this is we're gonna notice this after the first 24 hours after delivery, because if we're seeing a fever in that first 24 hours, that can be related to dehydration and different things from delivery. Okay, so if we're after that first 24 hours, we have 2 successive days of a fever of 100.4 or greater, there's something going on. All right, and this usually happens in those first 28 days. The first 10 days for your infection. So signs and symptoms of infection: fever, okay, maybe tachycardia, lethargy, not feeling well all over, stuff like that, okay. Endometritis is going to be our most common postpartum infection. And endometritis happens at the endometrium. The endometrium is the lining of the uterus. And so this usually starts right where that placenta was attached, okay, because if you guys see in clinical, placentas are pretty good size. And so there's a whole huge area that's just open and prime for bacteria. All right. So what we'll do for this, couple of things. First of all, if she's having a cesarean, we give prophylactic antibiotics because we're opening her uterus up, and now that's increasing her risk of bacteria getting to that endometrial site. We don't give prophylactic antibiotics though for vaginal birth, just for cesarean. But if we're seeing a fever, the first thing we're thinking is endometritis. All right. Other things that can be infections postpartum: wound infection. So right when we were looking at her laceration on the previous slide here, she can get infected there. Okay, that's why we're teaching her to use her peri bottle and to do all those things to keep her bottom clean. Women can develop urinary tract infections or cystitis, especially if they're having difficulties emptying their bladder. Okay, respiratory infections. And then mastitis is the other big one. So most often we're seeing endometritis or mastitis. And mastitis is the one I mentioned before on the breast. And anybody who's had mastitis before, guys, they will tell you that this is no joke. They feel like garbage. They feel like they have the flu. They feel bad all over. And their breast is so sore and so tender. And so the things that we need to do for these mamas is she needs to be on antibiotics. We need to have her taking analgesics and antipyretics, so Tylenol, ibuprofen. We need to encourage her to keep emptying that breast. Okay, she can still breastfeed with mastitis, but it's really uncomfortable. So we oftentimes teach them to start with their baby on the non-affected side, and then they can either pump the affected side or breastfeed on the affected side second, because we want her to empty that breast. Okay, number one, for her milk supply, but more importantly, to keep the infection moving out. Okay, so frequent pumping or feeding, warm compresses will help. So all those things we said about what we didn't want to do for someone who wasn't breastfeeding because we didn't want to stimulate the breast, we now, for this mama, this mastitis, we want to stimulate the breast. So warm compresses will help the milk let down. A nice hot shower and letting the heat beat on her breast helps the milk let down. Things like this that's going to help her continue to empty that breast is going to be important. The next thing on the bubble heat is Homan sign. And what we're looking for with this, guys, is a clot. All right, so think about the fact that in pregnancy, our moms are hypercoagulable, right? They have an increased risk for clots, and they are carrying this hypercoagulability into the postpartum period. All right, and so there's a few things that we're seeing with blood clots. So we're looking for superficial venous thrombosis versus a DVT or deep vein thrombosis, and then in its worst condition, a pulmonary embolism can happen. So for a superficial venous thrombosis, this is a superficial, it's in the name, superficial. This is superficial. They're going to be able to have some pain and tenderness in the lower extremity that they can palpate an enlarged and hardened vein in their calf. All right, we're not as worried about these becoming PEs. So we're going to have them rest and elevate. They can wear like compression socks. They can use NSAIDs for comfort. And this will resolve pretty easily, usually on its own. Our DVTs are more concerning. And this is where Homan sign comes from in that acronym. So I'm going to show you this with our bear again. Okay. And so what we're thinking about with a DVT is we're thinking about a deep vein thrombosis in the calf. All right. And usually they're going to have unilateral leg pain. They're going to have leg pain on the affected side. All right. That calf is oftentimes tender, swollen, warm, red. And our Homan sign happens when we dorsoflex the foot. And when we dorsoflex the foot, it causes, if they have a DVT, it causes a lot of pain in the calf. All right. And so doing this and getting pain in the calf is a positive Homan sign. All right. Now, as students, you typically will not assess that. And the reason for this is because doing that could risk dislodging the clot. And if we dislodge the clot, now we're worried about a PE. All right. So with our DVTs, we're going to treat those mamas with heparin. Okay. And she can still breastfeed when she's on heparin or Coumadin, in case she's worried about that. But it's going to need to be treated so she doesn't develop a PE. And PEs are pulmonary embolisms. That's going to be when our clot travels to the lungs. They're tachypnic, they're tachycardic, they're having dyspnea, chest pain. This is an emergency. Okay, and they're probably going to be on anticoagulation for a long time. So when we're talking about our venous thrombolytic disorders, we're talking about the formation of clots in the vessels, what we were just saying. This most often happens in the first 3 weeks after the baby's born. All right, they have increased risk of this if they have a C-section, especially if they are obese. And oftentimes, if we have an obese woman that has a C-section, they are automatically put on a prophylactic low-dose heparin for this exact reason. We use SCDs, which is synchronized compression devices that squeeze and relax the calves and mimic walking to keep from having venous stasis, right? So we are assessing pedal pulses, we're assessing edema, we're looking at the leg circumferences, we're looking for that unilateral change like we were talking about here. We don't want moms to rub it because we don't want to dislodge the clot. And then pain management, and that's about it. So the next thing on bubble heat is emotional status. We need to be mindful of the fact that a lot of women are at risk of developing postpartum depression. And we start screening for depressive symptoms even in the prenatal period, in their prenatal appointments. What we're using postpartum is the EPDS, which is the Edinburgh Postnatal Depression Scale. And the American Academy of Pediatrics thinks we should be screening these moms at 1 month, 2 months, and 4 months. Typically, those screenings even happen when they happen both when at their follow-up appointment with their OB, but they also are asking moms these questions when they take their babies to the pediatrician for those appointments, because they're going to be seen on these intervals. People who have a history of depression, anxiety, they don't have a good support system, things like that are at increased risk of developing postpartum depression. And we are going to, when we do postpartum depression in our discussion post, I'm going to post a video for you guys to watch. So watch for that. So emotional status, what are we thinking about? There's a few different things that we can see. All right. The most common one, up to 85% of women develop what we call postpartum blues or baby blues. And they are emotionally labile. If you remember when we talked about in pregnancy, how their hormones are all over the place and they become emotionally labile in pregnancy, this is going to be true in the postpartum period as well, because remember, all these hormones are shifting. And I tell moms, you're going to feel a little bit like a 15-year-old girl for a while, and that's normal. Okay, so they might cry easily, have difficulty sleeping. They're still going to be able to bond with their baby. It does not impair their ability to function. And usually around 5 to 10 days after, this is better. This is going away. Okay. Postpartum depression is much more intense, and they have the emotional lability and sadness and things like that, but their mood swings are much more pronounced, and they have more intense feelings that actually can cause feelings of detachment towards their baby, lack of interest in their baby, thoughts of self-harm, not acting on it, but thinking about it. You know, they don't really need me here. They'd be better off without me, things like this, okay? And this lasts more than 2 weeks. That doesn't mean we should wait 2 weeks to start going, wow, something's not right with you. All right, so we educate women and we educate their support system and their partners, especially if they have these risks, especially if they have a history of anxiety and depression. If you are not able to take care of yourself, if you don't want to get out of bed, you don't want to take care of your baby, you need to talk to somebody. You need to call your provider. All right. Usually this is going to improve. It takes months. And oftentimes they need therapy and medication to get there. All right. Postpartum psychosis is a much more pronounced problem and thankfully very rare, because this has postpartum depression on steroids. It has psychotic features with it. Okay. And they have rapid onset of bizarre behavior. They might hear things, see things, be paranoid, all sorts of stuff. Impulsivity. All right. Infanticide and suicide. So when you hear stories of women that killed themselves and their babies, things like that, this is the psychosis. All right. And they often need to be hospitalized to treat it. Attachment and bonding. So we did our bubble heat. We're going to look at some other things that go with postpartum. One of the things we do as nurses is we look for how they're attaching and bonding with their babies. Okay. We are looking for facilitating and inhibiting behaviors. And these are in your book. So you should look at this table. Okay. But we're looking at eye contact, touching, holding, singing to the baby. They want to change a diaper. They're trying to swaddle. They're interacting with the baby and with the baby's care. If we don't see this, then we're concerned about that these are inhibiting behaviors. We're concerned about detachment versus attachment. Okay. Skin to skin immediately after birth helps with attachment. So there's so many benefits. We're going to keep all term, we keep identifying, oh, skin to skin helps with this, skin to skin helps with that. And skin to skin is one of those things that does help with attachment bonding, both for moms and dads. Okay. If we have parents that we are high risk, we're concerned about their attachment and bonding, this is when we are going to spend more time helping incorporate them in the patient's care, in the baby's care. Also, increased risk for depression. That's a good time to also incorporate them in the baby's care. Have them rooming the baby in. Help them with baby care items. Teach them how to take care of their baby and see if you can start to foster that attachment. Okay, health promotion for future pregnancies. So the other thing we're doing postpartum is we are promoting health for the mom. All right, so if her rubella was non-immune, this is a good time to give her rubella. All right, and we usually give it as an MMR. So they usually will get this before they go home. They can breastfeed with it. The thing with the rubella, guys, is that it is a live virus. And this is why we want to give it to her right now when we know she's not pregnant. But if she gets pregnant soon after getting the MMR, there can still be some damaging effects to the new baby. So we want her to avoid becoming pregnant for at least 28 days, right? Because this is a live virus, it's going to trigger her immune response. So she might get a fever. All right, that's not abnormal. Varicella vaccine, that's for chickenpox. This is something that the CDC recommends. I don't see in practice that we're doing this where I am, but it is a recommendation that they get a varicella vaccine. And this is something where they would need to get a second dose on their postpartum visit. And again, it's a live virus, so they shouldn't get pregnant for 28 days if they get that. Tdap. Any adult that's taking care of a baby should be vaccinated for Tdap. And the reason for this is because pertussis is horrible for a baby. All right, their airways are so tiny, and pertussis is very, very bad for a baby. For an adult, we might contract pertussis and not even know it. It might seem just like another cold. All right, so anyone who's going to be taking care of the baby, so the parents, the grandparents, whoever, should get a Tdap vaccine. And then we're going to give moms Rogam. And this is the part where I would ask you, who gets Rogam? Okay, so think about this for a second. We're thinking about our moms that are Rh negative. And now the baby's born and we've tested the baby's blood and the baby is Rh positive. If we've got negative mama, positive baby, we need to give Rogam to suppress the immune response. And that way, she's not building up antibodies that would affect the next pregnancy if that next baby's also Rh positive. Okay. There's a couple of things to think about with this. All right. It suppresses the immune response. So we're also giving her rubella and asking her body to have an immune response. Okay, so if we have a mom that we're giving the MMR, the rubella to, and she's getting RhoGAM, we can give these together. All right, we should give them in opposite sides, and she should have a test for immunity of rubella in 3 months, just to make sure that her body built up enough of a response to it. It still should be okay, but we want her to get tested. All right. So RhoGAM, guys, we gave it at 28 weeks gestation if she was Rh negative, and now we're going to give it again at 72 hours after birth if the baby's Rh is positive. And it can be given IM or IV. She can also, with this, have fever, tenderness, malaise, things like that. And something to keep in mind, guys, is that the RhoGAM is made from human plasma. And so there's some people that, like Jehovah's Witnesses, that would decline blood products, that they might want to decline this. And so we have to provide really good education. All right. So postpartum hemorrhage, this is kind of a big part of what we're assessing for and managing the postpartum period, right? This is a very dangerous thing. So postpartum hemorrhage is the leading cause of maternal morbidity and mortality. And I have seen some really, really bad ones, okay? Risk factors are in your book. We consider blood loss greater than 500 mLs for vaginal delivery or greater than 1,000 for cesarean delivery is considered a hemorrhage. But I'm talking about women that are losing thousands, 3,000, 4,000, 5,000 mLs. Okay. We classify this as early and late. Early hemorrhage happens in the first 24 hours, and the greatest risk is in that first hour after the baby's delivered. Late hemorrhage happens 24 hours to 6 weeks after, and this is our subinvolution. When we have maybe a retained placental fragment, something in the uterus that's keeping that muscle from contracting down and tamponading those vessels. Okay. If she's losing all this volume, now we have a risk of hypovolemic shock, right? Most frequent cause of postpartum hemorrhage is uterine atony, absence of tone, that muscle's not contracting down. So we're going to massage the fundus and help encourage that muscle to contract. And if you're doing your fundal check and it's boggy, you're massaging and telling that muscle, squeeze. Okay? Massage is first. Massage, massage, massage. Encourage that muscle to contract. So we need to prevent bladder distension, right? Because they said if the bladder's pushing up on this uterus and we're finding it up here, it's not contracting well. All right. So it's often displaced up and to one side, usually to the right, but it could go either way. All right. And so if it's not midline and it's higher than where I found it before, I'm worried about bladder distension. So I can have my patient void, but guys, if she's bleeding, if I'm worried, I'm not ambulating her, I might straight cath her, I might place a Foley. I could offer her a bedpan if she's stable and fine. You're going to have to use your nurse brain and decide what's best. Okay. Retain placental fragments or retain placenta in general. So we have 30 minutes, right? Now we're talking about stage 3. We're backing up in our head to stage 3 with babies out. We're waiting for placenta. We have 30 minutes. All right. And if we have an abnormal implantation of the placenta, like they call it an accreta, where the tissue of the placenta has started to grow into the muscle of the uterus, then these are harder to get out. And we spend more time talking about that, I think, in week 6. So if we have abnormal implantation, retain placenta. If we're retaining the placenta, sometimes they even have to have, we have to go into the operating room and go in and get it out. All right. Other things to consider. So uterine atony is our number 1. That's what we're thinking. She's bleeding. Uterine atony is our number 1 concern. But number 2 leading cause of postpartum hemorrhage is going to be hematomas and unrepaired lacerations. So we had this patient, she was this young thing, first baby. She had preeclampsia, she was on magnesium, and she delivered her baby. And after her delivery, she started complaining of this pain in her back. She just was having this pain in her back, and her blood pressures were low. They were like 90s over 50s. And the nurse I was in charge that night, the nurse that was taking care of her, was calling the doctor and saying, I don't know what's going on with her. Her lochia looks normal. Her fundus is firm. She's having this persistent back pain, and her blood pressure is low. And so the physician says, well, let's give her a fluid bolus and see if that helps. Maybe her kidneys are bothering her. It'll help support her blood pressure. So they give her fluid bolus. And her blood pressure came up a little, and then it kind of inched back down. And the nurse is starting to notice a little bit of trickling. All right, her fundus is still firm, little bit of trickling of blood every time she's checking. And so she calls the doctor again and says, I want you to come to the bedside and assess. So he comes out, he looks, he doesn't see anything, and says, let's give her another fluid bolus and just watch it. And so that happens, and we're not getting better. And her pressures are going down again, and she's getting more tachycardic. So we're thinking, guys, hypotension and tachycardia is a really good indicator that we're having a volume issue. Okay, so she's getting more tachycardic. She's still having pain in her back. And so, and she's still having this trickle. And so, side note, if you have a firm uterus and trickling coming from the vagina, that is very indicative of a bleeding laceration. So we call, and the doctor comes out again, and this time he uses a speculum and he looks inside the vagina. And what he finds is all the way back past the cervix, he finds a laceration. And behind that, in the posterior fornix, is what he pulls out over 500 mLs of clot. So this is causing her back pain, all right? And he repairs this laceration. Her back pain's better, her blood pressure comes up, everything is fixed. She was hemorrhaging. Okay, so hematomas and lacerations is our number 2. And if we're having this trickle with a firm fundus, we're thinking laceration. Okay, hematoma, I'm going to show you a picture of a hematoma in a minute, a huge one. But hematomas are a collection of blood in the tissue, and you don't know if it's continuing to bleed in there. All right, and it's painful because the tissue is stretching and accommodating. And I thought my hematoma was on the next screen. We'll get to it. So guys, for hemorrhaging, I have slides in here that have red on top. And I brought these in actually from my hospital. I want you guys to see what they're teaching their nurses in the hospital for hemorrhage. And so it's part of what we're doing for class. Okay, so primary and secondary, this is what I said before as early and late. All right, primary in the first 24 hours are early, and then late is after 24 hours. So our primary in the first 24 hours or early hemorrhage, atony, retained placenta. If she has a coagulation defect, that can contribute to it. Uterine inversion, turning that uterus inside out. And then genital tract hematomas, and this should also have lacerations in here as well. These are our main causes for having hemorrhage in the first 24 hours. Here's our causes for after that: infection, subinvolution, retained placental fragments, and again, coagulation deficits. So here we're thinking subinvolution. We're having something in the uterus that's keeping that uterus from contracting down and going back to its pre-pregnant state. So for uterine atony, we know it's the leading cause of postpartum hemorrhage. And for this mnemonic, they're breaking it down in T's. Tone is our uterine atony. Trauma, so lacerations and hematomas. Tissue, retained placental fragments. And then thrombin is our coagulopathy. And that's our lowest incidence. So in this example, we're saying atony is 70%. So things that cause uterine atony, overstretched uterus, if she had multiples, if she had a lot of amniotic fluids, so polyhydramnios, things like that, that really stretched. She had a baby that was large for gestational age. She had a baby that weighed like 10 pounds. Things that stretch the uterus are going to increase her risk that uterus is going to be like, nope, I'm done. No more squeezing for me. I'm good. Okay. This is going to be a cause of uterine atony. Magnesium sulfate. So guys, we give magnesium sulfate to help prevent seizures in our preeclamptic patient. But if we are giving magnesium sulfate to help prevent seizures, magnesium sulfate also reduces the contractility of the uterus. And so my patient that I told you about, she was on magnesium sulfate. So that was kind of our first thought, right? But her uterus was firm. And so that's when we went to lacerations. Prolonged labor. Again, if she's been contracting and contracting and contracting for a long period of time, her uterus is tired. All right. Chorioamnionitis. We haven't really talked about this yet, guys, but chorioamnionitis is an infection that happens during labor. And it is an infection of the chorion and the amnion, which are the layers that surround the placenta and the membrane that holds the baby and the amniotic fluid and everything inside. Oxytocin use in labor. If we're using a lot of Pitocin and she's on it for a prolonged period of time, those receptor sites are saturated. Okay. Maintain good tone, assess contractility. How are we going to do that? We're going to do fundal massage. We need to prevent bladder distension. Okay. We've seen some repeat ideas here. All right. Placenta needs to be delivered in 30 minutes. They can remove it manually. Our abnormal implantations already mentioned, accretas, incretas, percretas. And that's where the placental tissue actually grows into the endometrium. So this is our picture of a hematoma. They don't all look like that, but I want you guys to understand what I'm talking about with the hematoma. Okay. So for our lacerations, let's talk about lacerations. Lacerations can be of the cervix, the vagina, the perineum. Here's pictures of examples. All right. Our first degree is more superficial. Our second degree is getting into the muscle. Our third degree gets to the anal sphincter, but doesn't penetrate it. And our fourth degree does penetrate the anal sphincter. So third and fourth degree, we are so close to the rectum. That's why we don't want to put anything in there and disrupt that tissue. Okay, so we can't do enemas, we can't do suppositories. We don't want them to be constipated because we don't want them to work hard to have a bowel movement, especially with third and fourth degrees. Okay, so preventing constipation. Hematomas are going to be bluish, purplish, edematous. Pain is usually the most common symptom, but if she had an epidural, maybe she's not feeling it yet. Right? We see them a lot more if we have an operative vaginal delivery, if we're using like forceps, and often they're on the vulva like this. Inversion of the uterus is going to be vigorous fundal pressure. So if we are not supporting and we're pushing hard up here, we can turn that uterus inside out. Excessive traction on the cord, tocolytics to relax. So if it turns inside out, we have to give a medication to make the muscle completely relaxed so we can put it back, and then give her oxytocin and make it contract down. Huge risk of bleeding with this, okay? And then subinvolution again is failure to return to the pre-pregnancy state. So we have prolonged lochia rubra or return to lochia rubra after it started to transition out. Etiologies for postpartum hemorrhage. This slide is just for you guys. It's the same thing we already saying. This is tone tissue, trauma, and thrombin, but it breaks it down and it shows you signs and symptoms, diagnostics, and what medications we use. All right. And medications, if you guys go to your packet that has the key topics at the end, there's a list of medications. You guys need to know those. And our hemorrhage medications are in there. And we're going to talk about them more today. Postpartum hemorrhage actions. So we can use this acronym to help think about what needs to happen. All right, we are going to assume the bleeding is caused by uterine atony unless we know that there's a different cause. And the very first thing we're going to do is massage. We're going to massage the fundus, and I really wish this slide had M for manage the bladder, because these are the two very first things that need to happen. Massage the fundus and manage the bladder. We're monitoring the vital signs. We need her to still perfuse her tissues. We need oxygen to still be going to those tissues. So we're monitoring her vital signs. We can monitor her INO. We're measuring the quantified blood loss. And guys, we can quantify blood loss by weighing it, right? So for every gram, that's a milliliter of blood. Medications, we're using our medications. I'm going to talk more about medications in a minute. We're mobilizing the team, phoning a friend, calling the doctor. And we're considering our T's, tone, trauma, tissue, and thrombin. Uterine tone, lacerations and hematomas for our trauma, tissue, retained placental fragments. Okay. And then we're preparing to transfuse. We have to restore the circulating volume. So she might need blood products. All right. So bleeding management, here is an algorithm that tells you what we're thinking about, what we should be doing. Okay. And this comes straight from your book. All right. And so it asks you, assessment to determine the source of the bleeding, anticipate doing labs, establish venous access. We need IV access. If she doesn't have an IV, we need one. And guys, we actually need two. And they need to be large bore, greater than 18 gauge, because we need to be able to pour volume into it quickly, and we need to also be able to put blood product through it. And we don't want something that is a small gauge that can lyse our cells if we're giving her blood products. And now it asks you, is the placenta out? If so, we're going to massage the fundus. Is the fundus firm? Then let's look for lacerations and hematomas. Okay. Over here, is it boggy? Empty the bladder. Okay. So guys, take a look at this algorithm because it tells you what needs to happen. All right. And you guys need to know this. This is a huge part of OB. Right? This is where women die. And this is how we keep that from happening. All right, so it'll tell you, give uterotonics as ordered. All right, so let's jump over here and talk about our uterotonics. These are on page 511 on your medication guide in your book. They are also on the key topics thing at the end. And so you need to be able to identify what the medications we're going to use are and what their contraindications are. All right, because you are your patient's safety net. And so here's what I mean. Let's look right now at Methergin. Methergin is a medication that we use to help the uterus contract, but it's contraindicated with hypertension because it causes vasospasm. Now let's think about for a minute, if your patient is hemorrhaging, is she currently hypertensive? She's not. She's hypotensive. Her blood pressure is low. So if you call a doctor into the room and they come in and they look at the monitor and they see her blood pressure is 80/30, they might say, let's give her Methergin. But you know that she has been hypertensive in labor. Then that's your place to say, she's been hypertensive. Would you like to use a different medication? So this is you advocating for your patient. Okay, so our uterotonics, Cytotec, or misoprostol. Cytotec is something that we use in small doses to induce labor. It's a prostaglandin. So for week 3, we talked about prostaglandins, how they soften the cervix. In large doses, though, it helps the uterus contract. So we can give Cytotec. We can give Hemabate. Hemabate is contraindicated with asthma because it causes bronchospasms. Methergin. Methergin is contraindicated with hypertension. Okay, and then oxytocin. Give her more oxytocin, encourage that muscle to contract down. So we're going to massage, We're going to express clots if there are any that are keeping the uterus from contracting. We're going to eliminate that bladder distension, empty her bladder. We want IV access, IV fluid. We need to maintain stable vital signs and O2 saturation. She has to keep perfusing oxygen to her tissues. Our meds, these are uterotonics. They promote uterine tone. Okay. If we are not getting what we need, if we're not getting her bleeding under control, there's other things we can do surgically. We can put a balloon inside her uterus and inflate it with fluid, and it will tamponade those vessels like a pressure dressing. We can do artery ligation, embolization. Sometimes we have to do a hysterectomy. We have to take the uterus out. All right. And I've seen this happen a couple of times. We just can't get a handle on it. So here's our medications again. Here's our uterotonics, the way they are administered, how often, and what our contraindications are. And again, see red on top. This is what they're sending out at the hospital. So hypovolemic shock. We might not notice that she is hypovolemic until she's lost 30 to 40% of her volume, because guys, we're talking about young, healthy women usually, and their bodies are really great at compensating and compensating and compensating and compensating until they just aren't anymore. And so signs and symptoms of hypovolemic shock are going to be the same as your med-surg patient. Cool, clammy, hypotensive, tachycardic, pale, weak, thready pulse, stuff like that. Our goal is to restore oxygen delivery to the tissues. We have to maintain our cardiac output. So we can give her oxygen, okay? And that's great, but guys, if we're not circulating it, that by itself is not the fix. We're going to give her oxygen. We're watching her level of consciousness, breath sounds. We got to restore the circulating volume. We have to be able to circulate the oxygen. So that's why 2 IVs are better. All right. And here's our blood product options. Okay. And we usually are starting with packed cells, packed red blood cells and platelets. FFP and cryo are good for giving back clotting factors. So in a second, I'm going to talk to you about DIC, and that's when these ones are helpful. All right. Mass transfusion protocol. And these are always evolving, but they are prepared to give you tons of volume. And it just runs like you get a cooler and you're pouring those in, and the next cooler comes, and you're pouring those product in, and the next cooler comes, and you're pouring that product in. Okay. And we have to treat the cause. If we can give her all this volume, but if we don't get a handle on where the bleeding's coming from, we're just chasing our tail. All right. So DIC, guys, this is a bigger problem with her hemorrhages. And what happens with this is the clotting factors in her body become very used up. It's a consumptive coagulopathy. And so we have an overreaction of the clotting cascade. And so all of these clotting factors get busy making all these tiny little microclots. And these little microclots aren't big enough to do any damage to her body, but they're using all the clotting factors. And so now she doesn't clot. All right. One of my students one time said that everybody went to a party and nobody went to work. And that's what's happening here. All the clotting factors are over here doing their own thing, and they're not doing what they need to do. So we see widespread bleeding. She might have petechiae where the blood pressure cuff is squeezing her. She could be bleeding from any puncture site, her IV site where we did lab draws. She could have blood in her urine, anywhere. And we have to fix the problem. Okay. Other coagulopathies we're thinking of. So when we're thinking about our T's, and thrombin was one of the things on the list, our coagulopathies are other things that are causing her maybe not to clot. And so coagulopathy, idiopathic thrombocytopenia purpura is ITP. ITP is an autoimmune disorder that decreases the lifespan of her platelets. And so it puts her at a really high risk of having a severe hemorrhage if she has a C-section or if she has vaginal lacerations. So oftentimes women with ITP get corticosteroids in pregnancy and maybe even in labor to help stabilize the lifespan of those platelets. We can also give platelets if we need to. All right, but this is something that good prenatal care is important with, so that when she comes in labor, or she comes in for a C-section, we already know. We already know she's already been treated with corticosteroids. We're promoting the stability of her platelets. And this patient, guys, we're ready in case she bleeds. So a lot of the things we do in OB are seatbelts. When you get in the car, you put your seatbelt on. You're not planning on wrecking your car, but it's hard to put your seatbelt on while you're going through the windshield. And the same is going to be true for our patients that are at risk for hemorrhage. If we have a high hemorrhage risk, they automatically get 2 IVs on admission. 2 large bore 18 gauge IVs, okay? Because I don't want to try to put a seatbelt on going through the windshield, and I do not want to try to place a large bore IV on somebody who's hemorrhaging. All right, so for this patient, she's getting 2 large bore IVs. I'm going to have my hemorrhage cart on hand that has all the tools I need. I'm going to have my hemorrhage kit that has my uterotonics, has all my medicine, and I'm 100% ready. Okay. Another coagulopathy is von Willebrand's. This is a type of hemophilia. They have increased risk of bleeding up to 4 weeks after. Oftentimes we see prolonged bleeding times with them. And these ones are treated with desmopressin. So this week we are reading chapter 18 to 21. I'm actually going to give you guys this in class. All right. So that is postpartum. All right. Let me know if you have any questions, and I'll see you in class.